The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/PPF 860. Downloadable slides and practice aids are also available.
Welcome, everyone. We're here to discuss challenges, controversies, and opportunities in the management of EGFR-mutant lung cancer with CNS metastases. So our panelists tonight include myself, I'm Catherine Beal, and then we have Dr. Aluaha and Dr. Patel, who will respectively give us their information and share their medical oncology and neuro-oncology perspective. We're going to go ahead and start with Dr. Patel, who will again come to us with his medical oncology perspective and speak to us about navigating and synthesizing the evolving evidence base in the treatment of EGFR mutant lung cancer with CNS Mets.
I'm going to focus on the systemic aspects of treatment in terms of the medical oncologist perspective, in terms of a multidisciplinary approach to managing brain metastasis in patients with EGFR mutated non-small cell lung cancer. And so we're going to talk about the biology of EGFR, differences amongst the inhibitors, CNS penetration, which is a key point in this particular topic, and then settings in which EGFR inhibitors are currently used in clinical practice. And so before we treat a patient with advanced lung cancer, it's key to make the right diagnosis. And I would argue that the diagnosis of a cancer patient with lung cancer involves these three key aspects. The first is a radiographic diagnosis with CNS imaging, ideally an MRI of the brain, and a CT chest abdomen pelvis or PET-CT that goes head to toe. Pathologic diagnosis, which involves biopsying the highest stage non-bone lesion because bone lesions are harder to, because of the calcification process, to get molecular information, and to try to get 3 or 4 passes of a large core needle biopsy through interventional radiology or sometimes through interventional pulmonology. And then the key aspect is we won't even know if a patient has an EGFR mutation if we don't test for this. And whether we use cell-free DNA-based testing, which is a blood-based biomarker, or tissue-based testing, the key is to test for the NCCN recommended biomarkers independent of smoking history for patients with non-squamous, non-small cell lung cancer who may be candidates for targeted therapy. And there is a bit of a red herring in testing. So PD-L1 IHC, which is one of the key biomarkers for utilization of anti-PD-1 directed immunotherapy, can be helpful, but there's a kinetic gap in which the next generation sequencing often takes 2 or 3 weeks to come back, and the PD-L1 testing comes back within 2 or 3 days. And so the red herring trap is that oftentimes patients with high PD-L1 expression, you may get that result back and you may not know the patient's sequencing information. You may act on that and treat the patient with pembrolizumab, and you may later find that the patient actually has a driver mutation. So one of the key pearls is to wait for the next generation sequencing results before treating a patient with metastatic non-squamous non-small cell lung cancer. And then if you can't wait, treating the patient with a cycle of chemotherapy such as carboplatin pemetrexed by itself without an immunologic can be a perfectly reasonable approach for a patient in extremis, and I'll get into why momentarily. And so the key is, even with driver mutation such as EGFR, ALK, BRAF, ROS1, these aberrations have pills that are targeted therapies that have substantially improved survival benefit as well as quality of life benefits for patients. You can actually have high PD-L1 expression concurrently with these molecular aberrations. And in fact, almost a third of patients with EGFR mutations will have high PD-L1 expression. So this is a trap, and so the way to avoid it is to make sure to wait for the next generation sequencing results for the patients before beginning their systemic therapy. And if you can't wait because the patient's highly symptomatic, consider radiation, consider chemotherapy alone, because if you try to give these patients immune targeted therapy after immune checkpoint inhibitor therapy, the risk of toxicities is much higher. And so one is you're going to get this red herring effect where you're going to get the PD-L1 back first, and you're waiting for the next generation sequencing return. But the other is that even if you gave this patient immunotherapy for these driver mutations, their survival, especially with EGFR mutations, isn't prolonged by immune checkpoint blockade. And so we're not really benefiting these patients, even with high PD-L1 expression, with these types of immunotherapies, because their best therapy remains targeted therapy to this date. And one of the key studies that was done in this area was looking at a biomarker-selected population of patients who both had EGFR mutations and at least 1% PD-L1 expression. And these patients who had never received prior therapy received pembrolizumab, which is an anti-PD-1 immunotherapy. And what was found is that the toxicity of this regimen involved a fatal pneumonitis. In fact, one of the key aspects in terms of testing for these patients is that if a patient gets an immunotherapy and then later gets an EGFR TKI, their risk of fatal pneumonitis can be as high as 5 to 10% in some series, and about a third of patients will have advanced pneumonitis. And so it's key to make the correct molecular diagnosis before treating this patient systemically. And so fundamentally, what is EGFR inhibition? So you do the right molecular test, a patient has metastatic non-small cell lung cancer, and you have a patient with an EGFR driver mutation. What exactly are we targeting? Well, one point to make about EGFR more broadly is if you treat colon cancer, you give drugs like cetuximab and panitumumab. These bind the extracellular domain. These are monoclonal antibodies that bind the external surface of the cancer cell. What we're talking about in non-small cell lung cancer is the tyrosine kinase domain, which takes ATP, which is the energy battery of the cell, and actually phosphorylates EGFR and leads to cancer growth. And so what we're doing with these small molecule pill EGFR inhibitors is we're blocking the ability for the battery to enter the kinase and thus shutting down that signaling. And so this is key in understanding exactly what we're trying to do with our small molecule inhibitors. And there are 3 generations of EGFR inhibitors. The first generation are drugs such as erlotinib and gefitinib, which had really minimal CNS penetration unless you used some atypical dosing schema, and they had wild-type inhibition in terms of rash and sometimes diarrhea as well. The second generation inhibitors such as afatinib or dacomitinib have questionable CNS penetration as well. They're irreversibly binding that pocket, so they're preventing wild-type signaling of ATP, but they do have more severe side effects in terms of rash and diarrhea. And for the drug we're probably going to be spending the most time talking about today, osimertinib. This is a drug that has excellent CNS penetration, crosses the blood-brain barrier at physiologic doses, irreversibly binds EGFR, and also actually has less side effects because of less EGFR wild-type inhibition relative to the first generation and second generation inhibitors. And so the majority of our discussion today will be centered, at least in the United States in 2019, around osimertinib, which is the standard of care in frontline for many patients, and I'll describe the data why. Now, like most drugs, cancer tries to evolve to bypass the drugs and their ability to try to mitigate cancer growth. And so what we learned for patients that received first-generation EGFR inhibitors such as erlotinib, gefitinib, or second-generation drugs such as afatinib is that their mechanism of resistance almost 2/3 of the time was a mutation called T790M. And so based on rationally designed drugs, the ability to design an inhibitor to this mutation and in addition target the exon 19 and L858R EGFR mutations, which represent about 90% of the mutations we find in these patients, was a key drug discovery challenge and led to the development of osimertinib. And so we look at the topic for today, which is comparing these EGFR inhibitors and discussing their best role with radiation and surgery. We find that the CNS response rates you see in the second to right column for the earlier generation agents such as afatinib is on the order of about 30-35%. But if we look at osimertinib, in some of the earlier studies in the refractory space, the response rates are closer to 70%. And then leptomeningeal disease, which is a very difficult disease, A, to ascertain response, but B, in terms of patient behavior and patient situations, the response rates are often quite lower. We see about a 35% response rate with osimertinib. And as these drugs have moved into the frontline space, favored over chemotherapy, favored over immunotherapy, as I discussed before, we find that if we look at some of the older agents, the CNS response rates in earlier stage disease when patients are a little more fit is probably in the order of about 70%. And if we look at probably the most robust data set that we have for modern era frontline EGFR-directed therapy with osimertinib, about 90% CNS overall response rate with first-line utilization of osimertinib, compared to about 68% in patients who got erlotinib or gefitinib in that same study. And so if we look at osimertinib, which is a third-generation EGFR inhibitor with excellent CNS penetration, we see that in patients with refractory EGFR-mutated disease, meaning they got a first-generation inhibitor and then an advanced inhibitor with osimertinib, that patients with CNS disease had improved progression-free survival over chemotherapy, and that this was retained with a hazard ratio of about 0.32, which is quite impressive. A hazard ratio, even about 0.7 is clinically meaningful, and so a hazard ratio of 0.32 is quite substantial for these patients. And so if osimertinib has efficacy in patients who received a prior earlier generation EGFR TKI compared to chemotherapy, how does osimertinib compare to first generation EGFR TKIs in upfront disease? And so that's the pivotal study FLORA, first line AURA, comparing osimertinib to erlotinib or gefitinib. Of note, patients with stable asymptomatic CNS metastases were allowed on the study, but one of the issues with interpreting data for CNS in this particular study is there's no mandatory baseline imaging. And so this is really a subset analysis because not every patient had baseline CNS imaging. And what we see here is when we compare osimertinib compared to drugs like erlotinib or gefitinib, which are very good first-generation inhibitors, there's a median progression-free survival benefit of about 19 months compared to 10 months with a hazard ratio of 0.4. And so even against a very good standard of care, osimertinib was superior. And part of the reason may have been osimertinib's superior penetration into the CNS and ability to prevent or treat brain metastasis. We see here that a subset of patients with CNS metastasis that received osimertinib, their survival was 15.2 months compared to those that got a first-generation inhibitor who had a survival closer to 9.6 months with a significant hazard ratio of 0.47. And this is retained even in patients who did not have CNS metastases. In terms of CNS progression for patients who received osimertinib, only 6% of patients had progression at the time in which this data was analyzed, which indicates that this drug is highly effective at control in patients with EGFR mutations. And so with the overall survival endpoint having been met, we see that even against a very good standard of care, such as a first-generation EGFR inhibitor, which even 3 or 4 years ago was the standard of care of this disease and represented an advanced standard of care, osimertinib reflects an improvement amount on that with overall survival benefit, CNS benefit, and progression-free survival benefit, both within the brain as well as extracranially. And the additional advantage of osimertinib relates to its toxicity profile as less wild-type binding than some of the other first-generation and second-generation inhibitors. And since these patients are going to be on therapy for a longer period of time due to their improved survival from this agent, the area under the curve, so to speak, for their toxicity matters in the sense that they're going to be on these drugs for a while, so cumulative toxicity can be an issue for these patients. And so we hear that the high-grade toxicity rate overall, and in particular for some of the EGFR-mediated toxicities, in particular rash, acne, dry skin, are improved with osimertinib. Now, one of the interesting things that really is an emerging data set is it seems when you use a drug like osimertinib, the resistance pattern, because cancer, like a bacteria, is always trying to find a way on what you're trying to inhibit it with, differs based on when you use the agent. And so if a patient had a first-generation EGFR inhibitor such as erlotinib, gefitinib, a second-generation agent such as afatinib, and then subsequently got osimertinib, oftentimes the resistance profile involves secondary mutations such as C797S, as well as loss of T790M. I'll get into small cell lung cancer transformation in a bit because this is something that can sneak up on us when we're taking care of these patients. But at least as far as we know for patients who receive frontline osimertinib, which at least in the US represents a standard of care adopted at many centers, we see here MET amplification seems to be one of the most common mutations that we see, and we see a different profile. And I think this is one of the things that's intriguing about the utilization of this agent and also how we can best intercalate these agents. One thing that can happen is patients who receive osimertinib, especially if at baseline they had an EGFR mutation, a P53 mutation, and an RB mutation, is in fact with that co-mutation rate, there's a over 40-fold excess risk of small cell transformation. So if the molecular profile shows EGFR, P53, and RB and a patient has rapid progression, think small cell, think about getting a biopsy, and think about chemotherapy with carboplatin etoposide, which remains the standard of care for this disease. This is a common pitfall in terms of rapid progression to EGFR, and these patients can be treated successfully with cytotoxic chemotherapy. And so what does this mean for my practice? I think the most important thing is that we test patients for the appropriate non-squamous, non-small cell driver mutations such as EGFR, ALK, and ROS1. And even if the PD-L1 is high, wait for the result for the NGS to come back, because if we try to give an EGFR inhibitor after immunotherapy, the risk of pneumonitis is high and can potentially be fatal. You can think about chemotherapy alone or radiation therapy for these patients, especially those with oligometastatic disease. And consider cell-free DNA or next-generation sequencing based on tissue for patients in terms of rebiopsy for those that you may not have enough tissue because their initial biopsy had to undergo the workup to make the diagnosis. And osimertinib represents a frontline standard of care agent with excellent CNS penetration. And I think the point I want to make about osimertinib is that it's not probably about 80 to 85% of patients will eventually have to deal with brain metastasis with this disease. And so the question isn't if SRS, it really is a question of when and when to optimally sequence, and that's what our discussion today will be about. Our patients receive a first and second generation EGFR TKI, which is rarer now as more and more patients get osimertinib frontline. Test for T790M to see if the patient's eligible for osimertinib, and consider SRS and chemotherapy for the T790M negative patients, where you can test in the tissue in the blood. For patients with symptomatic or large volume disease, especially in the posterior fossa, especially with significant edema, in terms of their CNS metastasis, a multidisciplinary evaluation is key, and prompt local therapy with either SRS or surgery is optimal. We typically try to limit whole brain irradiation for these patients because they may have prolonged survival on osimertinib, and we typically start osimertinib about 2 days after radiation or surgery is completed. And for those patients with asymptomatic or small volume CNS metastasis or leptomeningeal disease that will require aggressive whole brain irradiation, think about osimertinib, and then after a month do imaging with an MRI and consider radiation, especially stereotactic, to those areas that are not responding. And for those that are responding, you can defer local therapy, as osimertinib should retain systemic control. And so with that, I'd like to introduce my colleague, Dr. Ahluwalia, who will give us a neuro-oncology perspective into this difficult disease.
I'm going to start off by why does it matter when our patients have brain metastases. So obviously, as most of you are aware, lung cancer is the most common cause of brain metastases. So any large trials that you look at, half of the patients have the lung etiology. Until recently, the outcomes of our patients were fairly dismal. Most of these patients lived 6 to 12 months, but as we'll see in the following slides, a number of our patients are doing better, and hence neurocognition becomes a very important point when we treat these patients. So why it is important? We definitely know that the incidence of lung cancer brain metastasis is increasing because we look for it more. The new NCCN guidelines now ask, actually, when you see a patient with stage 4 lung cancer, that you actually do a screening brain MRI. Most of our clinical trials until recently excluded patients with brain metastases, so clinical trial screening involved brain MRIs. Now the trials do allow brain metastasis, but they want to know whether patients have CNS mets at the time of trial enrollment, so most of our patients on clinical trials will undergo a brain MRI. We do know that brain is a sanctuary site, so as our patients are better controlled, they'll develop brain metastases. The rates of brain metastasis also are influenced by the type of cancer they have or what kind of treatment is given. So a patient with stage 4 lung cancer can have up to 25% of the times diagnosis of brain metastases at initial presentation. And as Dr. Patel alluded to, if these patients survive more than 2 years, almost 80% of them will develop brain metastases. So you will see these patients in your clinic at some time or the other. Now we also know that as our molecular markers, and Dr. Patel talked about importance of molecular profiling in our patients has evolved, we are finding out the important role of these oncogenic driven tumors. So this was a multi-institution effort led by Paul Spiduto, which looked at over 2,000 patients diagnosed at multiple large tertiary care centers between 2006 and 2014, and they found a number of patients had alterations in EGFR, KRAS, and smattering of ALK. But what was important to see was that the median overall survival in a select group of these patients who were oncogenically driven was already improving compared to the others, which were either wild type or were driven by KRAS. So this is a slide which actually shows that when a patient with lung cancer with brain metastases comes and sees you, it's very important to know what's the primary driver mutation there, because these patients who have ALK-driven tumors actually can survive for almost 4 years. If someone had told us a decade back that we would have patients with brain metastases who would average live for 4 years, we would find that difficult statement to believe. But now we are seeing multiple series that these patients survive 4 years. Those who have EGFR-driven tumors live close to 2 years, and I think that number is only improving as we have better inhibitors, which we see in clinic. Those who have wild type or are KRAS-driven, still on an average they live around 12 months. So, and for those patients, maybe immunotherapy and some of the other new drugs may have promise. The initial GPA actually did not involve any molecular status. However, the more recent lung molecular GPA actually points towards importance of oncogenic driven status in these patients. So the way these GPAs work is, if you have a patient who's young, they get a higher score. A patient who's old gets a lower score. A higher score means better outcomes. So similarly, someone who has a better performance status will get a higher score. Someone who has a poor performance status gets a lower score. So someone who has a KPS less than 70 actually gets 0 points. If you have extracranial metastases, we know that's generally associated with poor outcome, so they'll get 0 points. If it is absent, they get 1 point. If you have EGFR or ALK mutation driven tumors, you'll actually get 1 point. And why it is important, if you focus on the curves on the left side, those who have higher GPA, they have really good outcomes. So patients who have oncogenic driven tumors typically tend to follow this particular curves, and you can see these patients live well for a long period of time. And as I stressed before, neurocognition becomes a very important point when we pick the right appropriate therapies for this, and Dr. Beal will discuss this further when she discusses her decisions as she sees these patients in clinic. So when we see these patients as a neuro-oncologist, the most important question for me is what are the goals of treatment? So when I see patients with brain metastases, I see it as a 2-compartment disease. We need to know what's going on in the body, but you also need to know what's going on in the brain. And in the brain, you basically have 2 components again. One is the macroscopic disease that you'll see on the brain MRI that you need to take care of. But you also need to be cognizant of the microscopic disease, because if you do not do a good job of controlling the microscopic disease, by the time you get the next MRI, that'll probably convert into macroscopic disease. And from a patient's perspective, a neurologic function and quality of life are critically important. And there have been trials now where neurocognition outcomes have actually been primary endpoints. And as you can see, there have been smattering of treatment strategies which range anywhere from whole brain radiation, combinations of surgery with either whole brain radiation or more focused forms of radiation. There was a lot of interest in radiation sensitizers along with whole brain radiation. We've done combinations of stereotactic radiosurgery and whole brain radiation. Chemotherapy traditionally had limited role in the management of these patients because most of our drugs did not cross the blood-brain barrier well. And that was the same issue as Dr. Patel alluded to with our initial generation TKIs. The new generation TKIs have an excellent blood-brain barrier penetration and are very reasonable agents to be used for these patients. And more recently, there's data of combination of these targeted therapies or immunotherapies along with radiation avenues. From a patient's perspective, when we treat these patients, you need to take a look at what are the number of brain metastases, what is the size of the lesions, because some of our treatments have size constraints, what's the location, what's the neurological deficits, patient's age and performance status are important, as is the primary tumor and the stage, extracranial disease, and also very importantly, patient's input. Because sometimes if you don't have evidence-based data to suggest a survival benefit, it's very important to discuss with patient what their wishes are and have that critically important as we make the right decision for these patients. So for the surgeons in the audience, there's still a role for surgery. If the patient presents with a symptomatic disease and it's a place where it needs to come out, we take it out. It's also important in some times where a patient presents with brain metastases. So the neurosurgeons are important. It helps us at least do local control. We'll talk some data about that, particularly in combinations with radiation-based techniques. Most of the times, our neurosurgery efforts are limited when someone has a single operable brain metastases, although Ray Savai and the MD Anderson group has shown that you can actually sometimes do it even with someone who has got 2 lesions. And the most of the benefit has been observed in patients who have good performance status and have controlled extracranial metastases. So this is this randomized trials that involved surgery. Most of them were done decades back, and 2 of them showed that when you combined surgery with whole brain radiation, which was basically the treatment that we used in 50s, 60s, and 70s, there was benefit at least in 2 trials. The median overall survivals were not very gratifying. On these average, these patients were living 40 weeks or so. So this is a slide which shows a number of various fractionation schemes, and without going into too much detail, there was no difference based on outcomes depending on what fractionation scheme you used. Although there's some data showing that 10 fractions may be better than 15 fractions. Then there was this landmark trial, the RTOG 9508, and whole brain radiation, which was considered the standard of care at that time, was compared to whole brain radiation plus stereotactic radiosurgery, and this was found to be statistically significant, although you can see the benefit was around 1.5 months. But these obviously were trials that were done where we did not have very good systemic treatments for our patients. And as you'll see, the numbers later on improve. So this was a trial that was led by Paul Brown and was a plenary discussion at ASCO a few years back. This was looking at patients with 1 to 3 brain metastases, looking at whole brain radiation plus SRS compared to SRS. And the patients were stratified on the basis of the lesion size. What this trial showed was that there was no difference in overall survival, but the primary endpoint was actually cognitive decline at 3 months. So the patients who got stereotactic radiosurgery had less cognitive decline as compared to those patients who got a combination of whole brain radiation and stereotactic radiosurgery. So this trial and a number of other trials have now led to primarily use of stereotactic radiosurgery alone in most of our patients with 1 to 4 brain metastases. As I said, now our patients with brain metastases are living longer, so neurocognition becomes a key component. And when we have used whole brain radiation, one of the challenges of whole brain radiation over the years has been the neurocognitive decline. As a result, there has been a number of efforts that have been undertaken to mitigate the impact of whole brain radiation on neurocognition, which included memantine drugs that can help in Alzheimer's. There have been trials that have looked at hippocampal sparing. A number of presentations have been done in recent years when there was a combination of both memantine as well as hippocampal sparing, and work led by Vinay Gandhi and Paul Brown showing that there may be benefit to the combination of both memantine as well as whole brain radiation and hippocampal sparing. Another key component that we see when we manage these patients is radiation necrosis. Radiation necrosis has been reported to occur in approximately 10% of patients who get treated with stereotactic radiosurgery. This has been described after patients undergo post-operative radiosurgery, which can range from anywhere from 4 to 18%. Risk factors that lead to greater incidence of radiation necrosis include repeated radiation to the same lesion or the lesion size. Our group looked at over 1,600 patients when we looked at those patients who got stereotactic radiosurgeries with concomitant systemic therapies plus and minus whole brain radiation. And what we found out is that if you combine both stereotactic radiosurgery and whole brain radiation with EGFR TKIs, you had a higher risk of radiation necrosis as compared to when you use these combinations with either SRS alone or just SRS plus whole brain radiation. Dr. Paul Spaduto also found that the incidence of radiation necrosis was higher when the EGFR TKIs were used as compared to stereotactic radiosurgery or whole brain radiation. The radiation necrosis symptoms can actually depend on where the lesion is and can vary from anywhere from seizures, mass effect, hemorrhage, hemiparesis, herniation, or personality changes. There are a number of strategies that can be undertaken to manage radiation necrosis. Steroids are often the first line of defense when patients present to us with radiation necrosis. If these patients are refractory to steroids or need steroids for long term, which we know steroids have multiple side effects, we have used bevacizumab to help us with both decrease in edema as well as getting rid of steroids. And our group basically showed that no matter you use the standard dose of Bev, which is 10 mg every 2 weeks, or you use 5 mg of Bev every 2 weeks, you basically find very comparable results. And we saw a significant reduction in steroid use when we used this. Surgical resections have been described to be used in this patient population, but can be associated with depression, systemic infections, and neurologic deterioration. In the last 5 years or so, there has been significant interest in laser ablation. So laser interstitial thermal therapy, a trial that was led by Veronica Chang, it was a multi-institution effort, showed that lit therapy can be a particularly good focus of controlling symptoms in those who undergo a proven radiation necrosis. Last few minutes, I'll touch on about leptomeningeal disease. As you know, patients with non-small cell lung cancer can get leptomeningeal disease. This number has been reported to be higher in those who have the EGFR-mutant non-small cell lung cancer. Various reports report leptomeningeal diseases in around 5 to 15% of our patients. Median overall survival from diagnosis typically is worse in those who have wild-type lung cancer leptomeningeal disease, which is typically around 4 months. Those patients who have oncogenic-driven tumors, the incidence of outcomes with leptomeningeal disease is better. It's typically 9 to 12 months. So I'll touch upon some of the Bloom data. This was using osimertinib at a higher dose. As Dr. Patel had alluded to, we use typically 80 milligrams once daily for managing our patients with brain metastases. However, because this involved patients with CSF penetrations, the higher dose of osimertinib was used in this trial, which was 160 milligrams every day. And key inclusion criteria was those who had EGFR mutant disease, who had a good performance status, and had leptomeningeal disease by MRI. A report of 21 patients showed that there was a benefit that was confirmed in 1/3 of the patients, but there was also stable disease seen in a number of patients that was confirmed. And as you can see on the right side, most of the patients who had normal brain function to begin with maintained that. However, we also noted that the 5 of the patients who had abnormal brain function or functional status to begin with also noted an improvement. So there is case for using osimertinib in patients with leptomeningeal disease. Now we also want to, when you have responses, we always have to not only look at what's the response rate, but as Dr. Patel alluded to, we also need to look at durability of response. So we clearly saw that osimertinib has more durable responses in brain metastases, and clearly, as you can see in this leptomeningeal cohort as well, a number of patients were maintained on a drug for a fairly long period of time, which varied from 7 to 12 months. So this is an option for our patients who have leptomeningeal disease. So now we are excited about our data. I would pass on to Dr. Beal, who will tell us how to manage now, since we have these TKIs which are working well, but we have traditionally used radiation to manage our patients with brain metastases.
Thank you for that very nice background on radiation for brain metastases. That was one of the better ones from a neuro-oncologist I've heard. Thank you. So we know in general how to manage brain metastases. In the past we used a lot of whole brain. Now we have surgery, SRS, some combination. Some chemotherapies are mildly effective, but with this whole new class of drugs, the TKIs, we have a rational combination. And how should we best combine radiation and TKIs? So this study that I'll start with is not exactly relevant to our decision making, but it's an important study. It was a study combining whole brain radiation therapy with erlotinib for patients with non-small cell lung cancer brain metastases, regardless of what their EGFR status was. So patients received 35 gray whole brain radiation and erlotinib 150 milligrams daily, and had an overall response rate of 86%. Importantly, there was no additional toxicity when erlotinib was given concurrently with whole brain radiation therapy. And the median overall survival was 12 months. But more importantly, the patients who had known EGFR status had an excellent response with a 19-month overall survival if they were EGFR mutant versus 9-month survival if they were wild type. So again, this study is not exactly relevant in terms of our decision making today, but it is a study that shows that it is safe to combine these drugs with whole brain radiation. So right after that study was published, we went back and looked at our experience at Memorial of our patients who had known EGFR mutant non-small cell lung cancer and brain metastases, and looked at how we treated those patients. We didn't have any sort of guidelines on what was best management. So we were treating empirically and went back and looked at our experience. Patients were excluded if they had received erlotinib before their diagnosis of brain metastases, and they were also excluded if they had a presence of a de novo erlotinib resistance mutation. So that left us with 110 patients. And of those patients, 63 were treated with erlotinib alone, 32 with whole brain, and 15 with SRS. And the ones who had any form of radiation received erlotinib afterwards. The median overall survival for the whole cohort is 33 months. So again, these patients have relatively radiosensitive disease and also disease that's sensitive to the drugs, so they do relatively well. The median time to intracranial progression was 17 months. And interestingly, there was a longer time to intracranial progression in the patients who had whole brain radiation, despite the larger volume of disease in their brain. And the patients who had SRS had a longer overall survival than those who had erlotinib alone. Now that group may have been a very biased group, probably patients with oligometastatic disease, the ones who were chosen to receive SRS. But again, it is impressive that the patients who had whole brain radiation therapy had a better outcome, longer time to intracranial progression. So here you can see on the survival curves, the black line here represents the patients who had SRS followed by erlotinib, and then the blue are the whole brain, and the red is erlotinib alone. Another study that was performed looking at a similar question was a multi-institutional study led by Magnuson from Yale. And he went back and gathered information from several institutions, including Memorial Sloan Kettering, Cleveland Clinic, University of Colorado, Vanderbilt, Yale, and UCSF. And this was a pooled multi-institutional study to determine, again, the optimal management of combining EGFR TKIs with radiation therapy. So first, Yale had done a single institution study and looked at the question of, what's the best practice pattern, and they found in their group that deferral of upfront radiation was detrimental to overall survival. So what happened when we put all this data together? First of all, we went through and looked at the patients who should be included. And again, it was patients with EGFR-mutant non-small cell lung cancer with brain metastases. And patients were excluded if they were on TKIs prior to developing brain mets. Again, if they had a TKI resistance mutation. We also excluded them if they did not receive a TKI within 1 month of either SRS or whole brain radiation. And likewise, we excluded them if they didn't receive SRS or whole brain within 1 month of progressing on a TKI. So we tried to keep the cohort similar, and so people were managed in a logical, similar format. And also, we needed at least 6 months of follow-up. Patients were again treated in 3 manners. One was straight EGFR TKI followed by radiation at time of intracranial progression, or SRS followed by a TKI, EGFR TKI, or whole brain followed by an EGFR TKI. And then typical or standard statistical analysis was done looking at Kaplan-Meier analyses for overall survival and intracranial progression-free survival. When you look at the patient characteristics, there are a few important points here. The patients who were in this first column received erlotinib alone up front, and again could get SRS or whole brain when they progressed. And about 75, the majority of them, I should say, were symptomatic, 75%, whereas the patients who had whole brain radiation therapy, only about half were symptomatic, and about half were symptomatic with SRS. And the symptoms could be anywhere from headache to something, or a more specific motor effect, something focal. Likewise, the patients who had whole brain radiation therapy had many brain metastases. About 40% of them had over 10 brain metastases. And then finally, the patients who underwent SRS had oligometastatic disease. The vast majority of them did not have extracranial disease. So there's a real selection bias, which makes a lot of sense of why you would treat some patients with SRS, the ones who have oligometastatic disease in their body and their brain. So if you look at the group of patients, just dividing them into who had radiation first versus erlotinib first, so this is a combination of whole brain and SRS, there was a significant difference in the group of patients who had radiation first followed by erlotinib versus those who had erlotinib first, followed by potential radiation at progression. And then if you break that out a little bit further, you can see the patients, again, who had SRS first did better than those who had whole brain and erlotinib. Again, that was significant. But again, the patients who had SRS first were the patients who were least likely to have any extracranial disease, and therefore had oligometastatic disease, where we have this sort of ablative approach, and we apply that to other types of cancers as well. So ablate as many sites of disease as we can. And then if you look at the overall survival based on the disease-specific GPA, again, patients who had a higher score, it's a better GPA. Those patients who had radiation first with a good GPA here in green, the solid line, had a very good overall survival, with median overall survival somewhere in the range of 5+ years That's remarkable compared to how long patients survived less than 10 years ago with this disease. And the patients who had radiation first but with a poor GPA or erlotinib first, either good or poor GPA, didn't fare quite as well, but still relatively well compared to historic controls. And in terms of intracranial PFS, again, there was an advantage with the patients who had radiation first versus erlotinib first. Some of the take-home points from this: the patients, again, who were treated with radiation first after developing brain metastases demonstrated an improved overall survival compared to those who received upfront EGFR TKIs. The SRS followed by EGFR TKIs demonstrated the longest median overall survival of almost 60 months, compared with whole brain radiation followed by a TKI, which was 30 months, and upfront TKI alone, which was 20 months. The disease-specific GPA, performance status, extent of extracranial disease burden, and the exon location of the EGFR mutation were actually equivalent between the groups, other than the extracranial disease burden was lower in the patients getting SRS. And then the benefit of upfront radiation, again, was most pronounced in the patients with that favorable GPA. So, which leads us again to that concept that's been emphasized here at ASTRO for the whole meeting, in fact, that treatment of oligometastatic disease and controlling and cytoreducing disease throughout the body may be actually very important in terms of long-term survival for all types of patients. So in conclusion, this study was important. It's a retrospective study, but it was well done. It gathered a relatively high number of patients, looked at very similar patient cohorts, and it showed that the use of upfront EGFR TKIs with deferral of SRS or whole brain might result in inferior overall survival. And again, it may be important that any form of radiation has a higher cell kill perhaps than TKIs in the brain. But we should use caution with the findings from this study, as the group had very limited disease or relatively limited disease, which is why we were treating many of them with radiation up front. And the majority of them had brain metastases at presentation. Although the risk of many of our patients, of these patients, is very high of developing brain metastases, the majority of them don't present with brain metastases. So it may be that this group of patients has a slightly different biology. If you're presenting with brain metastases, maybe that is the main driver and main disease burden side of your body, and that's the one that it's most important to control. So it is a specific group of patients that can't necessarily be applied to all patients with EGFR mutated lung cancer. In addition, this study used first and second generation TKIs. So now we've shifted to using osimertinib up front. So some of these results and conclusions in the study may not be applicable. Really a prospective randomized trial of upfront SRS followed by EGFR TKIs osimertinib versus an upfront osimertinib followed by SRS at intracranial progression would be needed to really clarify some of these questions. So there are, of course, other studies comparing upfront whole brain versus SRS versus EGFR TKIs. In fact, there's a whole host of them. None of them are quite as big or as extensive or as clear a cohort as the prior study that I just emphasized. But they do show that the survival is actually very long for many of these patients, particularly those who have SRS first. So this study by Gerber, the overall survival was 64 months for the patients who had SRS first. Again, the Magnuson study had 46-month median survival for patients who had SRS first. Overall, for all of these patients, you can just look through the overall survival column here and see that despite getting TKI first, TKI followed by whole brain first, SRS first, any sort of combination, the overall survival is actually relatively long for these patients. It's one of the reasons I really enjoy taking care of these patients. You get to know them and you can really be thoughtful about what the best management is for these patients in terms of balancing long-term goals of care, controlling their tumors, and then also avoiding toxicity and thinking about long-term how best to protect their brain. There was also a meta-analysis of 13 studies with about 1,500 patients with EGFR-mutant non-small cell lung cancer with brain metastases. They found upfront whole brain was superior, or upfront whole brain with SRS was superior to upfront TKI. Any sort of combinations did suggest that adding radiation up front was useful. But again, these are with older first and second generation TKIs. So right now there are a few ongoing trials that are recruiting and a few that are not yet recruiting but are planned to open soon. Mostly international studies. There is one that Dr. Ahluwalia is the PI of that's recruiting, and this one makes actually the most sense to me. It's for patients who have 1 to 10 brain metastases, and we give SRS selectively to the patients with the macroscopic lesions, so lesions that are over 1 centimeter, and then we manage the micrometastases with just drug alone and observe those on osimertinib. And the whole goal of this is to preserve not only neurologic function by preventing brain metastases progression, but also to avoid whole brain radiation therapy. So our current approach at Memorial Sloan Kettering right now is that if a patient has a brain metastases at presentation with limited systemic disease, then we actually usually do go for best control of brain with stereotactic radiosurgery. Typically, if a patient has 5 or less lesions, sometimes it will be 6, sometimes it will be 4. So it just sort of depends on each patient. If a patient presents with miliary disease, we will use selective SRS for larger metastases, whole brain radiation therapy very rarely, and we will add SRS for patients who progress with metastases on their TKI, osimertinib or otherwise. When we decide to proceed with radiation therapy, we will hold the TKI 2 days before SRS, the day of, and 2 days after SRS. And if we are giving conventional radiation therapy, whole brain radiation, or anywhere in the body, we actually do generally hold the TKI during the course of conventional radiation therapy, even though we do have that first study that showed it was safe to give concurrent. In conclusion, there are several considerations that we think about, and patients will live a very long time, or relatively long period of time, even in the setting of brain metastases with this disease. So we like to optimize local control for each lesion. We want to make sure each lesion is controlled as long as possible, and that's typically with SRS rather than whole brain radiation therapy. However, if you start with a osimertinib or any sort of TKI and they progress, salvage stereotactic radiosurgery is also another good way to control disease. We're trying to balance, again, the desire to control brain disease against neurocognitive function and potential damage from too much radiation. And again, for patients with oligometastatic disease, that concept of cytoreduction may be very important. Again, we have a very reasonable rate of response to TKIs with very good blood-brain penetration. We have similar rates of response to patients who have melanoma and undergo BRAF MEK inhibitor combinations. We generally see very rapid responses with these drugs. Some of the responses are durable, but we do monitor these patients and use caution with short follow-up on most occasions. So if a patient is started on osimertinib or other drug, we usually get a rapid follow-up within about 8 weeks of starting drug to make sure that they're responding, and if they're not, we will selectively treat the lesions that are not responding with stereotactic radiosurgery. This algorithm, I just want to point it out, this describes much of what we discussed today, and it is in your handouts. And now we're going to move on to the practicum and go back and revisit some of the cases that we mentioned at the beginning.
And so to review our cases, the first was a 64-year-old woman, newly diagnosed metastatic adenocarcinoma of the lung, PD-L1 high, IHC of 70% with an EGFR exon 19 mutation, at screening MRI had 3 small asymptomatic brain metastases without edema. And so just to the group, what would be your approach to this patient, maybe starting with Dr. Beal?
So she has 3 small asymptomatic brain metastases and other metastatic disease and an established mutation. I would actually monitor her and observe her brain closely with drug osimertinib.
Yeah, I think definitely osimertinib alone is a very reasonable strategy in this patient. Based on the data that we have seen, very high response rates in upfront setting. 90% of these patients will have shrinkage of their lesions. So definitely, I think that's a very reasonable approach. Obviously, as Dr. Beal had alluded to, we have data for first generation TKIs, primarily with erlotinib now, with that SRS and erlotinib may be better than just erlotinib. We just don't have the data in SRS plus erlotinib versus erlotinib. So as Dr. Beal alluded to, a number of trials are looking at these combinatorial approaches. So I think taking an approach of OC alone with a close monitoring of an MRI every 8 weeks to see progression of the disease, or a combination of SRS plus OC is also very reasonable.
I also would like to point out that this patient only has 3 small brain metastases, but for patients who have 3 or more, many of them will have an excellent response initially to osimertinib, but it may eventually progress. But it's not always the initial lesions they present with. They sometimes progress with new lesions. So there might not be any particular advantage of adding SRS up front as much as I like to do SRS.
No, it's a great point. And so at our center, these patients would get osimertinib. I think the key, there's a 6% CNS progression rate. So it's low, but it's not zero. And so typically, we'll start the patients on osimertinib and actually get an MRI about 4 to 6 weeks after with SRS sequences in case there are any lesions that are not responding or growing. And at that point, we would definitely consider SRS for these patients. And, sadly, it's really not a question of if SRS, it's really a question of when. And by doing SRS to lesions that may respond to osimertinib, we may prevent a different treatment plan later down the line to handle a refractory lesion. So that's one of the reasons we may initially prefer osimertinib in addition to radiation necrosis, which could have symptoms, and these patients have prolonged survival. And so this could be an issue for our patients. And I think, one of the keys is you often get the PD-L1 IHC back first before the NGS. And so think about waiting for the NGS results before treating with pembrolizumab monotherapy. Similar case, 64-year-old, newly diagnosed, PD-L1 high, EGFR exon 19 mutated, but rather than being asymptomatic, this patient on MRI has 2 centimeter lesions, significant edema, and clinically has headache and substantial motor compromise. How would the management change?
Well, with somebody who's got larger brain metastases that are symptomatic, I'd be very concerned about monitoring them. Our data for these patients in terms of response in the brain to drug alone includes patients with smaller asymptomatic lesions. So we actually don't even know the true response rate of a larger lesion, 2 centimeter lesion. Even if the response rate was 50% or even higher, I would still be worried and wary about monitoring these lesions, because if they don't respond and they grow, the patient could get into much bigger trouble. So I would favor doing some sort of local therapy, depending on the location, probably stereotactic radiosurgery to the 3 lesions. If there was something that needed to come out surgically, we would, of course, discuss it with our neurosurgeon.
Yeah, I would agree with Dr. Beal. Our effort would involve a local therapy in this case. Clearly, the patient is symptomatic, and most of these lesions up to 2 centimeters in size are radiation oncologists, neurosurgeons are very comfortable doing stereotactic radiosurgery and followed by osimertinib.
And then, one caveat is sometimes these lesions are posterior fossa. You're worried about uncal herniation due to swelling. These are often excellent surgical candidates, though radiation is appropriate. You can see a trend amongst our answers that, whole brain radiation is not our preferred modality for treating these patients, perhaps with leptomeningeal disease, but for those with discrete metastasis, stereotactic methods are preferred. And osimertinib with a high intracranial response rate is preferred over erlotinib. And with osimertinib actually having an overall survival advantage compared to erlotinib, the majority of patients in the United States, in my opinion, should be treated with osimertinib frontline as their systemic EGFR-directed therapy. So basically, to summarize, the first patient had asymptomatic EGFR-mutated non-small cell lung cancer, so osimertinib up front alone is reasonable. For patients with symptomatic or large CNS volume disease, SRS followed by osimertinib represents a reasonable approach, or if they have a solitary brain metastasis or posterior fossa, consideration of surgery for those patients as well.
45-year-old patient with EGFR mutation, positive lung cancer, excellent performance status, actually had a stage 4 lung cancer. So screening brain MRI was done. Patient was totally asymptomatic, and we saw these 25 brain metastases. I would ask my colleagues here, how would you manage this patient? We will start off with Dr. Beal. Would you do a whole brain radiation in this patient?
No, I wouldn't. I would actually, she's asymptomatic, they're small lesions. I would suggest medical therapy, osimertinib.
What would you do, Dr. Patel, in this case?
Yeah, I think likewise, upfront osimertinib, and for lesions that may not respond in a month, considering targeted SRS to those lesions that are not responding or growing may preserve the maximum quality of life while retaining CNS control.
No, I think, definitely our own practice is to try to avoid whole brain radiation in these patients. We often try EGFR TKI initially, and as you said, monitor these patients closely, 4 to 6 weeks, maybe 8 weeks, see the lesions they're responding. So what we did in this case was, this preceded the OC era. We actually used erlotinib. And this patient was treated with erlotinib alone for 8 weeks. When we did our 8-week scan, there was a complete resolution of all the brain metastases in this patient. So patient actually did well and was being followed. Then at 16 months, he had a CAT scan that revealed disease progression in patient's liver. Brain metastasis was still well controlled. We did the liquid biopsy, and we found a T790M resistant mutation, as was alluded by Dr. Patel, the most common resistant mechanism we've seen when we treat our patients with TKIs. So now, what would you do for such a patient who has a T790M mutation? Would you continue on erlotinib? Would you do SBRT? What would you do, Dr. Beal, if you was to see this patient in your clinic?
I would actually switch her from the erlotinib to osimertinib. We know that for patients who have that mutation, the response rate is quite high, even if they've developed that mutation on a prior TKI.
Dr. Patel?
Agree. I think for T790M positive patients who had a first-generation EGFR TKI such as erlotinib, osimertinib represents a reasonable standard of care for a patient who's minimally symptomatic or has lower volume disease.
So the last case is a 41-year-old woman. She's a newly diagnosed EGFR-mutant non-small cell lung cancer, stage 4 at presentation, with metastases to her bones, lymph nodes, bilateral lungs, and a screening brain MR reveals 2 brain metastases measuring 1.6 and 0.6 centimeters. She is asymptomatic. So these are her 2 brain metastases. You can see they're both in the frontal lobe here, not too far from each other. How would you manage this? Not discuss it. We can discuss it. She is asymptomatic, as a reminder.
Yeah, it's a good question. I think I'd have equipoise for starting osimertinib up front and seeing how that 1.6 centimeter lesion did with very close follow-up. The flip side is it'd be very reasonable to SRS the larger lesion, followed by osimertinib, and maybe watch the smaller lesion as well. And so I think there are a couple of reasonable options here, but I think the SRS upfront strategy, either for both lesions or at least the larger lesion, followed by osimertinib, would be one reasonable standard of care for this patient.
It's so tempting to just treat them both.
Yeah, that's right. Yeah.
Okay, and Dr. Ahluwalia?
Yeah, I would agree with Dr. Patel. I mean, I think the important things to consider in these patients are how close they live to your center, how compliant they are with follow-up. If there's a patient who wants to be treated with drug alone and is going to be fairly compliant, a close follow-up is reasonable. Obviously, larger lesion, definitely, you're tempted, but if you're going to do SRS, you might do SRS to both the lesions, since it's still a single-day treatment. So I think both the options would be very reasonable here.
Yeah, this case is a little bit complicated as well, because we don't, again, know what the response rates are with lesions that are 1.6 centimeters. It's on the larger side. On the other hand, she is asymptomatic, but she's got very limited disease in her brain, so we're kind of tempted to treat it as aggressively as possible and really control it. This patient did undergo SRS to both those lesions. She had 21 gray and then received erlotinib, and then about 12 months later developed radiation necrosis, which you can see right here, classic radiation necrosis. And this is a little bit of a side point, but when you actually look at these lesions on a sagittal view, you can see they're actually really quite close to each other. And one of the risk factors with stereotactic radiosurgery in terms of developing radiation necrosis is, of course, overall volume, but also there's some data that suggests that the D perhaps 10, 12, or 8 to 10 to 12 line is important. So the volume that's receiving 8, 10, or 12 gray of radiation. And in fact, that was actually a relatively large area given the proximity of these 2 lesions to each other. So unfortunately, she did develop radiation necrosis and ultimately underwent surgery to alleviate her symptoms related to that. She recovered from that uneventfully. And 2 years later, she developed 3 new sub-centimeter brain metastases on erlotinib. And this is in an era when there was no osimertinib available for her yet. And she remained stable extracranially. So how would you manage this patient now? She has 3 asymptomatic small new brain metastases in the setting of a prior course of radiation necrosis, very limited stable extracranial disease. Dr. Patel?
Yeah, I think it's a good question. They've been on erlotinib for a while. I think molecular testing for T790M is something we would do with the availability of osimertinib. But I think, for this patient, SRS would be a reasonable option for this patient, or you could continue to monitor closely. I think, in particular, I'd be interested to see what Dr. Alawaya thinks about
I agree. I mean, I think, we definitely, there are a couple of choices here which could be done, and I agree with Dr. Patel, on that. Clearly, I mean, if you find T790M mutation, you could switch to OC. Doing SRS would be a reasonable option too.
So I did treat the 5 brain metastases with stereotactic radiosurgery. So the original 2 and then the 3 for salvage. And then subsequent to that, she developed the T790M mutation and was resistant to erlotinib. So she was switched to osimertinib. So now she's been more than 5 years since her original diagnosis. Her brain remains without any evidence of disease. Her neurologic function is excellent. And her extracranial disease remains very, very limited, and she's maintained on osimertinib. We have a number of very good questions here. I'm actually going to start with the one that just came in from the top that is about SRS and radiation necrosis. What is my experience with that, and how do I manage it? So we have actually looked at the question of radiation necrosis extensively, and there are a few important kind of caveats in terms of understanding it. The definition of radiation necrosis is varied from institution to institution. The true pathologic confirmed radiation necrosis is one rate. The sort of suspected rate is another rate that might be 4 times higher. And then there's also a question of symptomatic radiation necrosis. At our institution, if we follow patients long enough, so for patients who survive more than a year and up to 2 or plus years, the true rate of radiation necrosis is probably broaches up to about 20%. Only half of those patients are perhaps symptomatic. And of those, at least at our institution, we end up removing surgically about 3 or 4% of those lesions. If they are in a location where they can't be resected or it's not medically appropriate, we often manage just with steroids and or we use bevacizumab. Rather judiciously, actually, and do see very good responses with bevacizumab, both in terms of getting patients off of steroids and symptomatic relief. Often we can give bevacizumab just for perhaps 2 infusions and reverse that process of radiation necrosis. If a patient has radiation necrosis and is asymptomatic, we actually just monitor them closely, typically with perfusion MRI, sometimes with FDG PET scans. I actually had a study looking at using fluorocholine PET scans to help distinguish radiation necrosis from tumor progression. Sometimes it can be very hard to distinguish those 2 processes, and that type of PET scan actually does seem to be useful. So we're investigating that more as a potential way to distinguish those processes.
Great. I think there's some other really good questions, and I totally agree in terms of radiation necrosis. One question, and I'll kind of just go chronologically, is the appropriate strategy for patients with brain metastasis only. I'm interested in timing and choice of local therapy and systemic therapy. And so I think, the first question is it truly brain metastasis only? A PET CT often can find an occult primary lesion. But in a patient with brain metastasis only, liquid biopsy with cell-free DNA may be an approach for patients who aren't surgical candidates. And in local therapy, if you are unable to make a diagnosis, or if they have oligo disease that can be treated with SRS, would likely be a preferred approach at our center for these patients. And sometimes by cell-free DNA, you may find a molecular aberration that you can target. And if this has a TKI that's CNS penetrant, for example, for EGFR-ALK, ROS1 now with some of the newer agents such as entrectinib, BRAF inhibitors, you can actually treat these in patients with low volume disease or symptomatic initially with CNS penetrant TKI, get close follow-up imaging and perform SRS to any residual lesions. But cell-free DNA is one of the ways of handling the molecular diagnosis for these patients, so it's important to do a PET CT to make sure to assess these patients head to toe. Anything else different you guys would consider in a brain metastasis only patient?
Well, we discussed the there are some cases we see where a patient will have the primary lesion removed, they have no other metastatic disease, and if they've got very limited disease in the brain, 1 or 2 metastases, even if they are having a response to a TKI, we will consider adding sort of a boost of targeted therapy, meaning a stereotactic radiosurgery. So with the concept of cytoreduction at its maximum, and then careful, close observation. My question actually as a follow-up to that would be, how long would you keep a patient on osimertinib if they've got a complete response?
Yeah, I mean, it'd be great if a patient, sadly that doesn't happen as often as we'd like, but for a patient who would have a CNS complete response to radiotherapy, I think a treatment holiday would be very reasonable. My fear is that there may be occult leptomeningeal disease or CNS disease that'll blossom, and so the idea that this patient will eventually need to be on osimertinib, though by using radiation we bought ourselves a treatment holiday, I think may be an approach, but otherwise it is effectively metastatic disease, and so these patients otherwise would be on lifelong therapy.
Yeah, I agree. I think the microscopic disease generally would manifest in this patient. So, as long as the patient's compliant and willing to follow up closely, you can give them a drug holiday. But obviously we found OC to be better tolerated than some of the first generation TKIs though.
I think in terms of the next question, I just want to clarify and address the third from the bottom here. Maybe Dr. Patel, you'd like to answer that?
Yeah, and so when would erlotinib be preferred versus osimertinib in the frontline space for a patient with an EGFR-mutated metastatic non-small cell lung cancer? I think in 2019, now that we know there's an overall survival benefit, we'll see the magnitude of that next week. But with osimertinib versus erlotinib, I think osimertinib remains the standard of care for the newly diagnosed and frontline patients with metastatic non-small cell lung cancer with EGFR mutations.
I would concur with that statement.
And I think another excellent question here is, and I don't think we know the answer to this, is what's the median length of response of brain metastases to osimertinib? I don't think we know that answer yet, but I think along the lines with that question is how often when patients actually progress on osimertinib alone, is it the original lesions that progress versus new lesions that develop?
Yeah, they're two great questions. I think it partially depends on the setting. Patients with leptomeningeal disease, both the response rates and the duration of response are sadly lower. If you look at the Bloom study for leptomeningeal disease, it's probably about a 30% response rate, and the duration of response is probably on the order of less than a year. If you look at FLORA, for the patients in which, while there wasn't baseline MRI for every patient, but the patients that did have CNS metastasis, the median actually hasn't been reached yet. Meaning these patients are doing quite well. And so I think it's definitely an outstanding question. We actually may see updated data for this next week with a more specific response, but the responses tend to be durable. And the thing that gives us credence to kind of wait for patients who are asymptomatic is that only 6% of patients will have progression on osimertinib as their initial therapy, and so 94% of patients will have disease control. And so for patients who may benefit from an initial systemic TKI strategy to kind of narrow the number of lesions that may require SRS to avoid radiation necrosis, that's one of the reasons an upfront osimertinib strategy may be reasonable there.
Yeah, I agree. I think we know that in recurrent disease, OC has definitely superior median progression-free survival compared to chemotherapy. Definitely, it was in the magnitude of around 8+ months. And as was alluded to, that was not reached when the FLORA data was initially read out. Maybe we'll get it, but the median duration of follow-up there was close to 14 months. So we knew that it's going to be more than 14 months. So I think the durability of response definitely with OC is quite good. And that's why I think doing OC alone may be a reasonable strategy for asymptomatic patients with brain mets.
Mm-hmm. Here's an interesting question. Should PCI, prophylactic cranial irradiation, ever play a role in non-small cell lung cancer? Dr. Ahluwalia, do you have a thought about that, or?
Obviously, typically our at least radiation oncologists tend to not do this. I don't know what's your strategy at Memorial about this.
Well, we don't routinely offer it, but it's an interesting question, and we do occasionally get into conversations with patients about this. There was a randomized RTOG study looking at the role of PCI in non-small cell lung cancer for patients who had responded with advanced stage, I think they were all stage 3, who had responded well to chemo, radiation, and sometimes surgery as well. And unfortunately, the study wasn't completed due to poor accrual. But early analyses did show that there was a reduced rate of brain metastases in the patients who did undergo PCI, which is logical. Obviously, there was no overall survival advantage, otherwise we would all be doing it. But I do still sometimes talk to patients who were offering stereotactic radiosurgery to for non-small cell lung cancer, not so much in this population because their response rate in their brain is so high, but with non-EGFR mutated lung cancer patients. And once in a while for patients who have brain-only metastases that we may be addressing with stereotactic radiosurgery, we will get into a conversation of adding PCI and perhaps in those patients even considering hippocampal sparing, adamantine, and so forth, because it seems that is their only high-risk organ of disease. But no, it's not a routine approach.
And I think at our center, we typically try to avoid whole brain approaches due to quality of life. And so PCI, which really means stage 3 disease, at least there's no OS benefit in non-small cell lung cancer. In fact, even in small cell lung cancer, there's a recent really nice study out of Japan that showed close MRI surveillance, if that's available in your jurisdiction, which in the US, MRI surveillance typically every 3 months is something that's covered. The survival actually trended towards being better. And so at least our institution, we don't offer PCI for patients with advanced, meaning stage 3 non-small cell lung cancer. Whether to do whole brain radiation after SRS really just depends on if we think they have leptomeningeal disease, for example. Sometimes they have bulky disease, and we may consider that. Though if they have a targeted driver mutation, such as EGFR, we'll often favor osimertinib plus stereotactic kind of approaches, and we may do sequential kind of stereotactic in that scenario. And so I think it's an area in which prophylactic approaches have not shown the kind of survival benefit I think we were hoping for.
Yeah, I have a little bit of a theoretic question. So the last case that I presented with the patient who has been alive and actually doing very well now, more than 5 years out, started on erlotinib, then gained a mutation, T790M mutation, now maintained on osimertinib. She's had a total of 5 brain metastases. What is it about a patient like that? She has very stable, very limited disease versus others who maybe present similarly but progress. What is it? Do you think the combination of changing from one drug to the next is beneficial? What's the difference in the biology, theoretically at least, from one patient to another?
Yeah, it's a great question. So, molecularly, what do we know about rates and kinetics of progression? One of the things we know is that the T790M positive clone is a slower growing clone than actually the exon 19 and L858R. And so there's a possibility for those patients, and we don't know why the resistance mechanism favors one versus another, but for those patients that have T790M positive kinetics who maybe got a first generation TKI and then got a third generation such as osimertinib in the T790M positive setting, that their kinetic disease may be lower. And that may be a biologic phenomenon. It wouldn't replace what we know based on the overall survival benefit from FLAURA of using osimertinib up front. And those patients that may have certain types of escape, for example, MET amplification, their kinetics will be very different than those that transform to small cell, which in fact would have a very aggressive kinetic of response. And so I think it's important to keep a close eye on these patients, even as they're doing well, because their biology can change on us.
Yeah, one question actually alludes to that the response rates with radiation are better with TKI. Why don't we lower the SRS dose? Dr. Beal, would you take that?
Yeah, sure. Well, at this point, our practice with osimertinib on board is to, if a patient has asymptomatic brain metastases, observe them closely on drug. And if they have progression of one or a few brain metastases, selectively treat those with stereotactic radiosurgery. And we don't actually know if lower doses in tumors that aren't responding would be appropriate. So we, at this point, generally treat with full dose. Also, those patients have disease that's already selected to be relatively small. That's why we were observing them originally. So the risk with treating those tumors with full dose is probably relatively low. And then for the patients who present with larger brain metastases that you might want to address with stereotactic radiosurgery up front, again, because of the size of those lesions, we probably don't want to dose reduce. And in something in the range of 2 centimeters, we're already dose reducing off of 21 gray, typically to 18 gray, or maybe even doing a hypofractionated approach. But that is something we need to study more scientifically. But at this point, we don't have enough data to dose reduce.
So we agree actually in our trial that is ongoing, we are keeping the standard doses of SRS as per the TOG criteria in our trial. But obviously I agree with you, we don't know enough about the interactions based on our retrospective review of 1500 patients plus. We found not too much increase in radiation necrosis as long as we use SRS with TKIs.
Right, and I think the only study that showed an increased rate of radiation necrosis was when we were doing SRS, whole brain radiation, and TKI, but we almost never do that now.
No, great points. And so 2 questions that kind of came in that I wanted to touch on because they represent kind of state of the art is the question is if a patient does not have brain metastasis and they have stage 4 EGFR-mutated non-small cell lung cancer, will be considered a standard of care treatment. And so that would be osimertinib, which had an overall survival advantage we know about regardless of CNS metastasis. And so I think osimertinib has largely supplanted the prior first and second generation EGFR inhibitors. And then a topic that is not exactly really the brain, but I think is something that's been very hot at Astro and probably worth discussing, is that for patients who, for example, get osimertinib in the metastatic EGFR positive setting, and then on follow-up scans have maybe a single lesion or 2 lesions that are left outside of the CNS. What about consolidative SBRT? This is an approach, at least at our site, for patients who get down to 1 lesion, for example, a primary lesion. We would in fact consider consolidative SBRT for these patients. I'd love to hear your guys' thoughts.
Yeah, we actually would absolutely do the same thing. If the patient is fit, responded well elsewhere, has very limited disease, and that concept of cytoreduction and obliterating as many potential clones as possible, we would absolutely consider doing that.
Yeah, I agree. I think our radiation oncologist would also favor the SBRT approach in this.
I do see there's this, I think we're up with time, but I'd like to address one last question. When would we consider bevacizumab for radiation necrosis? And it says, for instance, if you've had a limited response to dexamethasone, we usually start with dexamethasone. It's safe, low risk, and we'll start with a dose of dexamethasone to control the symptoms and then slowly reduce and try to taper off the dose of dexamethasone. And if we have a hard time tapering off and or if the patient continues to have symptoms, that's when we would consider adding bevacizumab at that point. But we usually start with dexamethasone as first line.
Yeah, we do the same, and typically we'll use slightly lower dose of bev, more like 5 mg per kg every 2 weeks, or 7.5 every 3 weeks, and we typically give around 4 doses, which for most patients will be sufficient to decrease the symptoms in most of our patients as well as take them off steroids.
All right, that's it. Okay, thank you so much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/PPF860. This activity is supported by an independent educational grant from AstraZeneca. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer View Institute for Medical Education.